Hereby I open this academic ceremony in which Angeliki Darma will defend the academic thesis Contemporary Management of Patients with Structural Heart Disease Undergoing Catheter Ablation of Ventricular Arrhythmias. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. So, dear Prorector, dear members of the Corona, dear audience, I'm very happy to be here today and to present my thesis on ventricular ablation of ventricular arrhythmias. The heart is essentially a pump, but its pumping is controlled by electrical activity. Every heartbeat starts in the sinus node, that's a normal pacemaker of the heart in the atrium. From there, the signal spreads across the atria and passes through the AV node, which briefly slows it down, and then through special fibers travels to the ventricles. In this way, the ventricles contract in a strong, coordinated way. On the electrogram on the bottom right, we can see the normal conduction pattern with the contractions of the atria with the P waves and the contraction of the ventricles with the Aquarius complexes. And this represents a regular heartbeat. When this electrical pathway is disturbed, rhythm disorders or arrhythmias can develop. In patients with heart failure, arrhythmias are common. About 1 in 4 will experience ventricular tachycardias or VTs. In ventricular tachycardia, the normal conduction system is bypassed. Instead, the impulse travels in a loop around scar tissue, for here in this example, on the apex of the left ventricle, and then fires back signals to the ventricle very quickly. The ventricles then contract so fast that they cannot fill probably with blood. This causes dizziness, fainting, or in severe cases, sudden cardiac death. On the electrogram on the bottom left, you can see an example of VT. The rhythm is fast, wide, and completely different from the normal ECG from before. VTs are life-threatening and always need an urgent treatment. Standard therapy of VT is to implant defibrillator devices in order to protect the patients from sudden cardiac death. But we also need to protect them from getting recurrent shocks because they are painful and psychologically devastating. One treatment is catheter ablation. Using thin wires, we enter the heart through the veins and create a so-called electroanatomical map. Once the abdominal signals are identified, we use radiofrequency energy or freezing to eliminate them. In this way, we cannot cure the underlying disease, but we can prevent the triggers of these arrhythmias. Ablation has been shown to be an effective treatment for many patients, and it's now part of an established guideline-based therapy for VTs. This figure shows what we see in the electrophysiology lab. We use fluoroscopy and these 3D electroanatomical maps in order to visualize the arrhythmias. In this case, this is so-called activation map. We see the wave or the circuit of the VT originating in the apex of the left ventricle. We see some scarring in this area, and then the VT begins there and travels back in the basis of the heart. This can help us visualize the targets that we want to ablate. So in my PhD, I focus on 3 questions. How can imaging help us plan and guide the ablations? What are the acute and long-term outcomes, including complication and complex procedures? And what is the prognosis after ablation? What drives long-term survival? Regarding pre-interventional imaging, in Europe, we usually use mostly CT and MRI imaging, which can provide essential information on anatomy and the location of the scar. On the right, you see CT scans. We can see the right and the left ventricle. We see the adjacent vessels, aorta, pulmonary artery, the coronary vessels, phrenic nerve. And with these yellow and reddish colors, we can see where exactly the scar is located. The brown areas are the dense scar. The yellow areas are borderline tissue. Similar scans we can get from MRI. We can see with these white patches the scarring, in the first case on the apex of the left ventricle, in the second case on the lateral wall. And we can integrate these images in special programs like ADAS or InHeart, and these programs can kind of guide us onto where to expect the VT circuits. So we have a very good idea where the arrhythmia is even before the patient enters the electrophysiology lab. But what is the prognostic and diagnostic value of these images? We, in our study of about 150 patients that underwent MRI imaging before the ablations, we were able to locate and measure the scar tissue. And this scar tissue, the burden of the scar was not predictive of the outcome of the ablation, but the location of the scar had a good prognostic value. And to be exact, patients that had a septal scar, a scar in the wall between the right and the left ventricle, had a worse prognosis. This case shows a 5-year-old patient with a genetic condition called LMNA cardiomyopathy. You see on the image of the MRI this septal scarring. And in this area, we were able to induce many VT circuits. We can see here the so-called voltage map of this patient. On the left is the right ventricle, on the right is the left ventricle. And the voltage map showed exactly what we saw in the MRI, that he had scarring on the high septum. And we were able to ablate these VTs with a freezing catheter in this case. He had a very good outcome from the ablation because he didn't have any arrhythmias induced on the end of the procedure. But we saw that in this patient, the heart failure deteriorated quickly. And after 2 years, he needed to get on the transplantation list. So this brings us to the central issue. How effective are these procedures and what are the risks involved? 2 decades ago, the only treatment for VT was antiarrhythmic drugs like amiodarone. While not invasive, these medications are often problematic in everyday life because of common side effects. On the other hand, a catheter ablation is invasive, carries certain complications. Its efficacy varies on the underlying cardiomyopathy, but it has been shown in many studies to be superior to drugs. In reality, the patients we treat are often very sick, and we need both of these treatments just to stabilize them. And in many cases, we need to assess the procedural risk. That means to assess the states of the heart failure, to assess important comorbidities. And in selected cases, we need temporary mechanical hemodynamic support just to undergo these procedures. So how are the results in real-life cohorts? In our study, we analyzed more than 300 patients undergoing VT ablation. On the right is an image from such an ablation. This is a patient that had a lateral myocardial infarction. You can see that with the red scarring in this image. The purple area shows healthy myocardial tissue, and what is in between is the so-called borderline zone. And these points mark pathological potentials, and you can also see the catheter ablation. In this case, is radiofrequency ablation, and we try to eliminate all of these points in order to perform what is called substrate modification. So the acute success of these procedures was about 80%. 4 out of 5 patients did not have any arrhythmias induced at the end of the procedures. And this came with a 4% complications rate, which is supposed to be acceptable in this kind of ablations. But we saw that in the long-term follow-up, after 3 years, 2 out of 5 patients had a recurrence. In some patients, the arrhythmia originated from the outer surface of the heart. In these cases, we needed to go not through the veins, rather than through the sternum. And this makes the ablations much more challenging technically. And we analyzed this cohort of epicardial ablations in over 240 patients. They were successful in the vast majority of the patients. 9 out of 10 were not inducible at the end of the procedures, with 5% complications rate, which is relatively low for this kind of special ablations. Here, too, the long-term success was about 70%. So, as we saw, not all patients remain arrhythmia-free after the first ablation. Sometimes we need to do repeat procedures. We analyzed the data of these repeat procedures in over 200 patients, and here we saw again 4 out of 5 remained arrhythmia-free, but in long-term outcome, 2 out of 5 had recurrence of the VTs. But what was interesting in this study was that the repeat procedures were able to lead to a significant reduction of the so-called VT or shock burdens, the numerical episodes of VTs or shocks that the patients had to endure. This is shown in the illustration on the right, and this is the situation before the ablation in number of shocks on the right, and the situation after the repeat ablation on the left. These findings show us that VT ablation is a process. VT recurrence can happen. It doesn't mean that it was a failure of the procedure. Important is to try to slow down the progress of the heart failure, and maybe we will need repeat ablations for this sick population. What about risks? Although VT ablation is generally safe, tamponade can happen. This happens when the catheter perforates the cardiac wall and bleeding occurs in the pericardial sac. We analyzed data of over 1,000 ablations in the last 15 years. The perforation rate was about 1.5%, and most of the patients were able to be treated with pericardial drainage. 9 patients needed surgery, but most importantly, all of them survived to discharge, showing that standardized management of these complications in tertiary clinics with heart surgeons on site is very important. So what happens to these patients after ablation? Looking beyond the procedure itself, the long-term prognosis is shaped mainly from the stage from heart disease. 1 in 3 patients died in the following 3 years, and half of the deaths were in the first year after ablation. Interestingly, the main cause of death was not arrhythmia, was not incidence VT, rather than the progress of heart failure, showing that VT is often a marker of advanced disease rather than a phenomenon that's isolated. And we found, furthermore, that certain comorbidities, all clinical features such as atrial fibrillation, larger left ventricle, or male sex were associated with higher risk of death after ablation. This means that the outcome for many patients depends less on the ablation itself and more on the underlying disease and the comorbidities. So this raises a difficult but important question. When is it the right time for each patient to shift our interest from repeat ablation procedures to more aggressive heart failure measurements, such as assist device or heart transplantation? This is a question that a coordinated team should answer. We need heart failure specialists, electrophysiologists, device specialists, radiologists, intensive care physicians, surgeons, and anesthesiologists. In certain cases, geneticists, and all of that in a tertiary clinic with rehabilitation programs and ideally telemonitoring. So, to conclude, imaging in VT ablation is essential. It can help us plan the procedures precisely. Ablation is effective. It can reduce VT recurrence, can reduce hospitalizations, and the complications rate are declining as the experience grows and the technology advances. Long-term outcome depends largely on the underlying heart condition comorbidities, so that a tailored approach is necessary. And finally, coordinated multidisciplinary care is vital to achieve the best outcome for this sick population. And with this, I would like to thank you for your attention, and we'll be happy to address any questions. I give back the word to you.
Thank you very much for your presentation. It's now time to start with the opposition. And the opposition will be opened by the chair of the assessment committee, Professor Brunner La Rocca from Maastricht University. He is professor of cardiology, in particular clinical heart failure.
Well, dear Prorector, thank you very much. Dear candidate, first of all, I actually would start to congratulate you with a very nice thesis. So very interesting to read. I learned a lot. And of course, I also would like to include your promotion team in the congratulations. I actually would like to discuss an aspect of chapter 3 with you, also something that you presented here, you showed predictors of outcome after VT ablation. Was it a surprise for you to find these actually these predictors, or how would you interpret that? You already said something about it, but I'd like to hear that again.
Hi, list proponent. Thank you very much for your comments. I think the predictors we found in our cohort were not a surprise, to be honest. We know that what drives the survival in these patients is not the VT, it's more the heart failure and the comorbidities. There are certain risk scores. Pain is this, for example, is one of that we use very often in clinical practice, and all of them show the same thing, that at the end of the day, it's the patient as a whole and not the arrhythmia that will drive the long-term outcome.
Yeah, no, I certainly agree with you. The question is, with these kind of scores, or also the finding that you have, is, well, what does it mean? What's the impact for the clinical practice? And that's something I would like to hear from you.
Yeah, sure. I think the problem is that we used to think that if we treat the VTs in these patients, then they will be stable for the next 10 years, and that doesn't seem to be the case. I think we have been more sensibilized in the last years to discuss these patients even after successful ablations with heart failure specialists, because in many cases we have missed the point where this patient could get an LVAD device, for example, or could get transplanted. And I think that's very critical, that even in successful ablations that we need to think further.
Well, happy to hear that you still need the heart failure specialist, so that's fine. But still, I mean, using this score, what is the clinical value of it?
Yeah, in some cases we also need to withdraw aggressive treatment, and I think that's also a point that it's not very pleasant in every day in our daily practice. But if we have a patient that has a very poor prognosis, then maybe it's not the best thing to do to put him on the operating table and try to ablate VTs for hours. I think that this course is kind of a marker for us. What should we expect? Because we have this finding very often that patients come for VT ablation when it's too late.
Yeah, I agree with you, but still with these kind of scores, to be honest, I think they are of no value at all, because you don't really adjust therapy based on these risk scores. Of course, if a patient is really towards, well, terminal disease, then you obviously, well, probably don't do an ablation, so I agree with that. But as you also know, in heart failure, this is really very, well, difficult to predict until the very end, and then it's actually clear that this patient will die within a short period of time. But before that, it's difficult, and even if somebody is really at high risk, the score doesn't really change practice, I think. Do you agree with that?
Sure. At the end of the day, it's a discussion that we need to have with the patient. We need to present the options that we have. We need to present the reality of these options, and we need to make an informed decision. But of course, a score will not tell us if we have to treat patient A or patient B. That's at the end of the day.
What could we do actually to use scores for clinical decision making? Do you have any suggestions? Clinically, but maybe also scientifically?
We use them as kind of a screening, to be honest, to see how possible or how likely is it that this patient will be able to go through this ablation and does not have any complications with that. That's the only value that I see right now for this kind of scores. But after that, it's a personal decision. Every patient and every subset and every ventricle is different. VT ablation can be very demanding, can also be surprisingly easy in some patients, but we all know that after the procedures, and then we have a very clear image of what we expect.
Yeah, okay, but when I interpret that correctly, then you say, well, this part of chapter 3 about long-term outcome and predictors is basically useless.
I wouldn't say it's useless. I think it's important for us to understand that if we ablate the VT, it doesn't mean that the patient will live for the next 20 years. I think it's more on this base that that was interesting
there,
for us.
I really agree with you, but for this you don't really need a risk score.
Yeah, sure.
And I personally think that what we need to do are studies based on, for instance, risk scores or other, typing of the patient, and to do interventions based on that. But you also said that you screen beforehand, and then obviously we need to do trials based on that. Another point that actually surprised me in chapter 3 is you didn't really mention much about medication. And when you talk about it's basically heart failure that, determines outcome, obviously drugs are really crucial. You also mentioned in your presentation several times, just drugs, but you didn't mention anything about the drugs. So how do you see that, or why didn't you include that? Or maybe you have, but you haven't shown it.
Because the cohort that we presented were optimized heart failure therapy.
What is optimized heart failure therapy?
That's a big question. These were studies that were conducted over the cohorts, and the ablations were conducted over the last 12 years. We didn't have agents that we have today. And of course, the outcomes 10 years ago were not the same, but on every single point before a patient was put on the operating table, we tried to do that with medication. There were some small exceptions in young patients with myocardial infarction, where maybe not every antiarrhythmicum that we know was tried, but all the other, it was at least we tried at least to put them on optimized medication.
Well, I think I would have liked to see that, because, of course, if you have the same patient treated by different doctors, it's very likely that you end up with a different kind of treatment, because it's not really that clear what it really means, optimal medical therapy, how far somebody goes really to treat, or to up-titrate, or when somebody's reluctant to really do that. There are quite some factors. So it would have been nice to see that. And maybe just very briefly as a last one, you find that antiarrhythmic therapy has a negative impact on outcome. So must we stop?
No. There is a certain bias in this outcome, because for example, amiodarone is the antiarrhythmic drugs that we give in most of these cases because of the structural heart disease. And we know that if we have to give amiodarone after ablation, there was a reason for that. We had many VTs, we had difficult substrate. One is not that confident that the outcome would be excellent, and I think that's what this outcome
I agree with you, but it would have been nice to really see that, and maybe to do analysis on that, because I think it even could be that it's actually increasing risk instead of reducing. But of course, I think the time is over. I would like to thank you for your answers, and would like to give the word back to the prorector.
Thank you very much, Professor Bruno-La Rocca. Just as an intermission, if the paronyms want to sit down, that's fine. Well, an hour is long to stand. We reserve that for the candidate.
Yeah, thank you.
The next opponent is Associate Professor of Physiology, Dr. Boukens from Maastricht University.
Yeah, thank you, Prorector. Well, congratulations with your thesis. I think it's a very good thesis with a lot of chapters published, which is very good. So I want to congratulate you and also your supervising team, and also the cover. I find it also beautifully chosen, so it's really nice. But I would also like to discuss some part of the content of the thesis with you. And I wanted to start with the propositions. And I thought, would you like to read proposition 1? Or read out loud, I mean.
I need my reading glasses, sorry. One. Yeah. Yeah? Okay, sorry. That's the problem. You said number one?
Number one, please, yes.
Catheter ablation should be considered earlier in the treatment of scar-related ventricular tachycardia rather than a last resort option after electrical storm or multiple ICD shocks.
Thank you. I think it's a very strong statement, and which maybe I also agree with. Still, I have some questions about it. So you write down scar-related. Why did you write down scar-related?
Estimable point. Scar-related, I only wrote that because that was my focus on this PhD.
Oh. So could you also write non-scar-related?
Of course.
Yeah,
in this case, it's even earlier.
Okay, even earlier. So the scar maybe relates to the substrate. Or
yes.
Not? Yeah.
I think the problem is that ablation for scar-related VT was considered a palliative treatment for many years, and it has evolved so much in the last 10 years that we can and we should offer it earlier for these patients, because the older they get, the more comorbidities they have, the worse the outcomes we have. And if a patient has a re-entry, a scar-related re-entry, it will not go away.
No. All right, thank you. So actually, if the anatomical substrate is not a scar, but, for example, a patient with structural heart disease through a different cause, would you then also would like to ablate early?
It depends on the patient, and depends on the findings, and depends on the imaging. If we have an idea of that being some kind of functional block, yes, because we can still visualize that in the procedures. There are many techniques that we can see that, and we can see where we should ablate.
Where we should ablate, yeah. And I think for diseases like Chagas disease or maybe ARVC, it's very clear. But in the recent years, it has become apparent that also patients with the Brugada syndrome actually have a structural heart disease. So what are your thoughts about that? Would you also ablate?
This is an interesting field. Brugada, long QT patients, we used to think about them as some kind of channel disorder that doesn't have substrate, but the data of the last 3 years, I think, tell us something else. And we have limited experience, to be honest, with this kind of patients. But in the 3-4 cases that I have seen, they really do have some kind of scarring. We can provoke it, for example, in Brugada patients with Ashmalin, we can see the differences. But I think we have very much to learn in this area. We still don't know what the endpoint should be in comparison to normal scar-related VT. But I think it's one of the fields that will occupy us in the next years.
Have you already ablated a Brugada patient in your
clinic?
Yeah,
we had actually a Brugada patient last week. I had amazing ECG. It was a poor 30-year-old patient with multiple shocks, and that was not his first ablation, it was his third. Okay. I think he doesn't have a good prognosis, but it was very interesting to see that he had substrate in this area on the epicardial side.
All right, so maybe in a few years from now, the first proposition will be true for almost all patients with structural heart disease. I would like to stretch it even more, because I think in patients with the early repolarization syndrome, it also has become apparent that in a large portion of these patients, also a structural abnormality is the cause of the arrhythmia. What are your thoughts about that?
I haven't seen a long QT patient, to be honest, on the operating table. We know
that would be with a prolonged repolarization, but I would mean early repolarization.
Yeah,
so the ERS as abbreviation.
I have seen only one patient in the last 15 years that had this syndrome. It's very, very rare in Germany, very rare. But it would be very interesting to examine that and to see what kind of substrate they have. I think the basis on the pathogenesis is similar. There is overlapping in these syndromes, and I expect that if they have it in long QT, the same should happen in the other kind of diseases, but I don't have any experience with that.
Yeah. All right, well, thank you. I have another question, and that relates to, I think it's chapter 1 on page 8. And that's the introduction. And I think in line 6, you write, in contrast to VT that occurs in individuals with structurally normal hearts, VT in patients with structural heart disease present a significantly elevated risk for sudden cardiac death. And I was thinking, so we do a lot of experimental studies with intact hearts, and in normal hearts it's very difficult to induce a VT. So we have to prolong repolarization by blocking one of the delayed rectifier currents. So I was wondering, what kind of VTs do you mean in normal hearts?
Outflow tachycardias, RVOT VTs.
Okay.
That's a clinical issue that we have maybe once or twice a month. Most of the patients, the VT is located on the RVOT side, and they are young patients without any visible structural heart disease. The imaging is always clear, and they present some of that not with PVCs, rather than with sustained VTs.
Yeah. Okay, that's a very good answer. I was thinking that patients with long QT syndrome or with CPVT also have a structural normal heart. And I think these arrhythmias increase the risk on sudden cardiac death. So that was my reason that I got triggered by this sentence. But you convinced me. I think idiopathic outrotract tachycardias is a large portion of these tachycardias. Is there still time for one question? Yeah, for one question. And that relates to chapter 9 on page 165, and that's the discussion. And I was wondering, are you familiar with zigzag conduction?
No.
No, zigzag. Well, zigzag conduction comes from a study from the early 90s, from De Bakker in Amsterdam, who actually looked at conduction in the infarcts. And you actually cite the paper because it's reference 15 in your discussion.
And I should know about the zigzag conduction.
And what you write is that chronic fibrotic tissue adjacent to healthy myocardium can create channels of borderline tissue which are crucial in the pathophysiology of reentrant VTs. And the next sentence you say, these slow conducting areas. And actually, the zigzag theory says that conduction in the infarct myocardium isn't slow, the path is very long. So therefore it makes a zigzag. So that means that actually it's not slowed conduction, it's delayed activation that creates an arrhythmogenic region in the isthmus, where the activation front exit again. So I was wondering, does that matter, that knowledge? Does it matter for your practice or for therapy?
So I think that you mean the issue is here the 3D, the three-dimensional VTs in the myocardium.
Yeah, so not the macro reentry, but really that you use the small channels inside the infarcted myocardium.
It can be important in the clinical practice because the expansion of these scars over from endocardium to epicardium can be tricky. And if we don't reach the channel from the endocardium, then I need to know if it is kind of a zigzag circuit, because then I need to ablate on the epicardial side. We don't have to find the exact mechanism in every VT in every patient, but it can be relevant if we have recurrence. If we don't, then we didn't understand what exactly was the mechanism of this VT. Yeah. And maybe patients with myocardial infarction, it's a little bit easier because normally we could reach everything from the endocardium, but it becomes very tricky when we have a non-ischemic dilated cardiomyopathy patient with this kind of substrate.
Yeah, yeah. Thank you. Yeah, I was also thinking about the new therapy that is now emerging, which is gene therapy. And if you are using gene therapy to reduce arrhythmia risk, then maybe you want to know the electrophysiological characteristics of these bundles, and then it matters whether it's slowly conducting or not.
I know there are some publications on this subject, and they're amazing because ablation is always a destructive procedure. This would be, to my knowledge, the only treatment that's actually healing the heart instead of damaging more. But I don't have any experience with that.
That will be for the next.
Sure.
Yeah. Well, thank you for your answers. I'm very satisfied. I give the word back.
Thank you very much, Dr. Boukens. The opposition will be continued by Professor Linz, Professor of Comprehensive Atrial Fibrillation Management at this university.
Thank you, Prorektor. Dear candidate, first of all, also congratulations to this very, very nice thesis. So I really enjoyed reading this thesis because it actually covers this complete journey of a patient with VT from pre-procedural, procedural, post-procedural workup. And I actually learned a lot while reading this. I would also actually congratulate, of course, the supervising team, which, together you who actually got to know each other during DASCAM, which I think also represents really this advantage of those postgraduate training programs of ERA together with the Maastricht University here. So in addition to those nice words, I also have now some questions. Yeah, and actually I would start first with some questions concerning one of your first chapters focusing on multimodal imaging. It's very impressive, of course, what we can do at the moment, right? Actually, we have a lot of different imaging modalities, CT, MRI, during procedures, electroanatomical mapping, and so on and so on. And by this, we zoom in to something what we think is the mechanism of this arrhythmia. Then on the other hand, industry provides us now tools which maybe do not really fit quite well to this very focused and detailed analysis of the substrate. So I'm referring there mainly to pulse field ablation. So all of those paragraphs and most of those patients which you actually included were treated by radiofrequency before the PFA era. PFA will come, most likely also on the ventricle. So how do you think do those large footprint catheters using PFA still need the very detailed assessment of the substrate, or do we just bombard with PFA then and areas, and do we need maybe to zoom out to actually get the right target?
Highly esteemed opponent, thank you for your comments. PFA will come in the ventricle because it's very, very aggressive and it seems to be very effective. The problem is that if we combine PF and RF energy, we can create lesions that are 1.5 centimeters deep and 2.5 centimeters wide. If we do that 5 times in a ventricle, the patient will not have any ejection fraction left. And I think that this will happen because everybody wants to try the new interesting tools, and everybody wants to do the VTs quickly and painlessly, without imaging, without detail mapping, and etc. But I think it should be used with very limitation, if I express it correctly, because it's too aggressive for the ventricle. And we also have the problem of cardiac stunning. We don't really know how effective or how aggressive our lesions are. We don't know how to titrate them, and these are all okay for the pulmonary veins, but not for the ventricle. I believe that at the end of the day, maybe not large footprint catheters rather than bipolar catheters with dual energy, the small tip catheters, 4 millimeters. I think we have to use them in such cases like LV summit or septal VTs or areas we don't usually reach the depth that we need to reach with the RF energy, but we need to use them with caution.
Yes. So you already refer to this dual energy concept, right? Actually still maintaining the old school radio frequency and then actually the very modern and fancy pulse field ablation on top. If you actually would have dual energy, would you first do with the one and then with the other, or would you decide on which energy used actually based on your pre-imaging, pre-procedural imaging, or how do you want to integrate this actually in the future? What do you think where the field goes?
I think when we're trying something new, we need to try it with modestly. So I would, if I had this catheter tomorrow, I would do what I do every time with this catheter. First the mapping with a multipolar catheter, then use the RF. And if I still have recurrence and I think, okay, the VT is probably a little more on the intramural or on the epicardial side, then I would do I would try to give locally some PF impulses on top of that. and as we gather information and experience, then maybe a little bit more aggressive, but not directly with a large football catheter in the half of the ventricle. I don't think that's very wise.
Yeah, no, very, very good. Actually, still concerning this multimodal imaging. So there was also one paragraph in your, or one chapter in your thesis where you actually saw that pre-procedural light gallium enhancement does not help you too much to predict outcomes after the ablation. So I would actually say that the pre-procedural imaging doesn't have to do a lot with the substrate, which actually undertains recurrences after the ablation, because there was the ablation in between.
Yeah.
So if you would redo now this study and, for example, instead of pre-procedural imaging, you would use post-procedural imaging, do you think that this post-procedural imaging might actually predict or help you to predict recurrences better? So what do you think?
I don't think so, to be honest, because I think VT is too complex to simplify that with scar burden. And the other issue is that mostly in the non-ischemic patients, we see substrate in the voltage meter that we didn't see in the MRIs. And I'm referring to the area around the valves. We have very frequent this kind of diffuse intramural scar underneath the mitral valve, and it's big substrates that MRI didn't catch at all. And even if we used one sequences, we cannot see that, and we cannot quantify that. That's why I think that even after the ablation, it would probably be not conclusive again. But that's a speculation. I don't know. I don't have the data.
Yes, yes. So you also had focus, of course, on epicardial VT ablation. I think there also, again, quite impressive, very big numbers of procedures, which you could actually include there in your thesis, which I think is very unique there. So if I would not know it's a VT or AF manuscript, I would also accept this as a very good AF manuscript, actually with 300 procedures and stuff. But so epicardial VT ablation. Then again, a little bit back to this pulse field ablation. Yeah, so I don't want to ban it now in the ventricle first. So, for example, if you would actually have a procedure where you might not get with your radio frequency and maybe very dosed dual energy catheter into the depth, so do you think that in the future with also more modifiable PFA applications and waveforms and catheters and things like this, you might actually get transmural to your epicardial substrate, or is this something what you think will not be achievable in the ventricle?
I think it will come to that. That's what the data say that we see right now, but I think we have also used that also in the epicardium, and we can create transmural lesions. I think the epicardial access will probably be used less in the future because of systems like that, but the thing is that we still need to work out all the possible complications or risks around it, because there is the problem of coronary spasm, for example. We don't know how to solve it yet. And there are multiple case reports or case series that this can happen. We also have problems with the His-Purkinje system. These are all questions that we need to answer before we take a system that's now off-label and use it for every patient. But we had, for example, a patient in June that had 4 ablations from LV summit, one of them epicardial. He still had recurrence, and he was ablated on the epicardium with a large tip catheter. But yes, that's a bailout strategy. That's what I mean with that. Yeah. I think it will come, but we need to slow it down a little bit.
Yeah, still a lot of studies to do. So thank you very much for those answers, and I would like to give the word back to the prorector.
Thank you, Professor Lins. The opposition will be continued by Professor Volders, Professor of Genetic Cardiology at Maastricht University.
Thank you very much. Dear candidate, congratulations. Wonderful work, very relevant for the field and the treatment of ventricular arrhythmias, a field that I love a lot. It's a very interesting field, also for mechanistic insights. I congratulate you and the team, Professor Van Nooy, Dr. Dagres, Dr. Terbeke. And I also wish to express my respect for the way that you treat these patients with very serious, threatening disease at the moment that they go through the worst time in their life. That is definitively not an easy situation in most cases. So that is my respect to your work. We are not here to do that. We are here to discuss scientific aspects of your thesis. And I have many, so I look forward very much to this conversation. And the time will be too short, and the church bells are already ringing. But let us start in chapter 9. You conclude that neither late gadolinium enhancement core mass nor borderline mass are predictive of post-procedural VT inducibility or recurrence in patients with structural heart disease. And then on the table that you provide in that chapter, table 2 on page 163, you also conclude that there is a lot of diversity of the patterns, transmurally and epicardial patterns or epi to endocardial patterns among the different cardiomyopathies. And if you cut the whole population down, then you end up with 63 patients with ischemic cardiomyopathy and even less for other conditions. So if you would have had the resources and the patients, wouldn't you have preferred at least for this particular chapter to focus on one population rather than the mixed bag of call it many different patterns of zigzag in a minority for all these patients?
Hi, Mr. Thank you for your comments. Of course. The thing is, we try to include every patient that had an MRI in our institute from 2015. Every one of them, they were unfortunately not 300 patients where I could do what you suggested. And we want to see if there is a difference when we examine the ischemic versus the non-ischemic patients. There isn't. We did a sub-analysis in this with these numbers, and we didn't find any difference. Maybe if we had 3 times these cohorts, maybe it would be different. Mm-hmm. And I expect in sorts of dense scar in the myocardial patients, I think they would have another outcome, especially concerning the prognosis, not the VT ablation outcome, but I think for that it was a little underpowered.
Okay. Other centers have claimed that if you use high-resolution CMR, you have much better prediction or much better assessment. For instance, they do that in Johns Hopkins University in Baltimore. Here in Maastricht, we do a high-resolution 3D dark blood CMR. So you could also argue, well, you use an inferior technique by doing this kind of structural analysis. How would you defend the approach that you took there in view of these aspects that are published?
Of course, we didn't have the newest or the MRI system that's in the world. Of course, there would be a difference, but we had the advantage of having this number of VT patients, and we had the advantage of having standardized approach for every patient that came in the EP lab, was scanned from our cardiologists. They had the same protocols, and we could have homogenized cohorts. But of course, it's the limitation that we have in the studies we conduct in the center.
Yeah. And you could also have a discussion on whether you are able to have high-resolution imaging of the structural problems that may be related or that are related to the VT, or whether you fall short in identifying the electrical abnormalities that come with those structural abnormalities. And that is in line with the remarks of Dr. Baukens, who actually stresses the importance of, well, wanting to know fibrosis is one thing, but understanding the complexity of the electrics that underlie VT arrhythmogenesis is another thing. And you might want to, develop techniques which are currently not available, I think, by which this is possible. So I cannot blame you for something you didn't do because it's not available. It's only to give a perspective towards the future of where you want to go if you want to understand better. Would you agree with the need for better understanding of the electrical abnormalities, or would you rather stay with the characterization of fibrosis?
No, I agree. The problem is the hemodynamic stability of the patients. We try to change that now because In Leipzig, we had the problem that the patients were not intubated. We didn't have Impel or ECMO for the large majority of the patients because of possible complications. So we needed to adjust our ablation technique on the technology we had and on the clinical daily life in the hospital. But we now try to do more activation maps of the VT and understand the underlying mechanism, and it has shown us many more details, but we need to have the setup for that. If we have intubated patients with anesthesiologists on site and Impella in half of the cases, of course we can examine that much better, but sometimes we need to be practical.
Very nice remark. My last question is the following. You were a very active and good participant of the DASCAM course. You also had a module that was entitled How to Set Up an Arrhythmia Unit. Now, you are going to the next Eisleben Center, which is not existing, but let's imagine that it does exist. Considering what you just said, what would you do different in making better assessment of VT substrates in patients by the combination of techniques than what you have available now?
I think at the end of the day, it would be ideal if we have imaging with the best devices that we can get. If we have anesthesiologists, if we have intubated patients, if we had heart surgeons on site.
Okay, you want it all, and then it will be
it
very
all.
expensive.
Exactly.
Thank you very much. I give the word back to the prorector.
Thank you very much, Professor Volders. It's now time for the last opponent. It's Dr. Langveld, cardiologist at Maastricht University Medical Center.
Thank you, dear Prorector. Congratulations to your candidate, to you, to your research team. I prepared questions of several chapters, actually, but I wanted to start with chapter 7. It's about male and female patients undergoing VT ablations, and I was a little bit puzzled about the results because female patients were referred later, less well treated, had more inducible VTs, and still their outcome was comparable. I thought the outcome would be worse. What's your explanation for that?
Still abundant. Thank you for these remarks. I think this was the most surprising cohort for us. The thing is that women are underrepresented. They are 10% of all VT studies, if that. So we don't have enough data. And in the previous studies, they had a worse outcome compared to male patients. The problem was that they are often compared 1 to 9, and the results of this analysis are often misleading. What we saw was that was true. They came later as in comparison to the men, and they were not that keen to have this kind of procedure. They mostly prefer antiarrhythmic drugs. I think that was the reason that they had more arrhythmias induced. But I think there are anatomical issues like the depth of the scars that we can reach easier probably in myocardial tissue in women. And that is a speculation that maybe we reached epicardial or intramural substrate because the heart was thinner. But I think that in many cases we don't need that aggressive approaches when we are treating 50 or 60 kilo women in comparison to 120 kilo male patient. But again, we also didn't have that many women to be able to draw certain results. This cohort was also
But were the women
modest.
reluctant to undergo the procedure, or we as a cardiologist are reluctant to send them to the cath lab?
Actually, both. We saw that women are less reluctant to do invasive procedures generally, but also the operators, my male colleagues, were also a little bit more not afraid to do them, but they have more respect when it comes to an RV-VT in a woman in comparison to a man.
But do women have more complications then?
I think that we all have this kind of bias in our heads that elderly women have more complications in AFib ablations, and maybe like without noticing that we project that to the VT procedures, but they didn't have any more complications than men.
And you said women perform usually worse in different studies, but in your study in chapter 3, male gender was an independent predictor of mortality. So that's something different from VT recurrence, I know, but...
Yeah. Whereas this is a result that we got with 90% of them being male. There is bias in this kind of analysis, we all know that.
But also the other study in which you say women perform worse also has 10% women.
Yeah, no, but I think that this field is not examined enough. If you search for literature on this case, there are not that many articles to find. And I think they are different. The pathophysiology is different. The way they respond to this ablation is different, but we need to examine them more.
And do you think if we treat them better up front, heart failure medication or maybe antiarrhythmic drugs, they perform better than men?
I cannot say that for every patient. It depends on the cardiomyopathy. The women that come with ischemic cardiomyopathy are mostly a little bit older because the disease doesn't happen until they're 60. But there are other cases like sarcoidosis, for example. There are more women than men in our register. They have worse prognosis. It really depends on the underlying cardiomyopathy.
Okay, thank you. The other question I wanted to ask you is about chapter 6. It's about cardiac tamponade in patients undergoing VT ablation. It occurred in 1.5%, which is comparable to the literature you presented. I think it's courageous to report this because no one likes to report their mistakes, their complications. Everyone wants to report their successes. But I think it's important you did so because I think you need complications to learn from, to make sure that in your next patient you won't get your complication and make the procedure safer. And if I listen to you, I think you are a clinical cardiologist performing VT ablations, very eager with their patients because you know examples of patients you did in the last weeks, what they had, how old they were, what kind of substrate they had. Did you or are there some measurements taken during the process of this cohort, because it was a cohort of a very long time, to improve patients' outcome, or what would you improve?
Thank you for this remark, because I think that everyone that has done a VT ablation in his life knows how modest we need to be in these procedures. And this 1.5% tamponade rate included all the epicardial ablations as well. And in these kind of ablations, for epicardial procedures, the complication rate that you find in the literature is between 6 and 10%. We were lucky enough to not have this kind of rates, but this was also dependent upon very, very, very experienced hands that were doing this. So I think that this kind of, for me, it's the most difficult procedures that we perform in field of the EP, and we need to have mentors that can teach that, and we need to have a team that can do that. And even if we have a complication, the management of the complication needs to be standardized. We need to have education of the whole team, doctors, nurses, in usual 2 times a year or 3 times a year in order to practice this. And we need to have surgeons on site when we perform this kind of ablations. I think these 2 points are critical if we want to that the patient survives, even if he has a complication, which is at the end of the day what we need to do to manage it. Because everybody has complications. If they don't do enough or they're lying. And we need to know how to do them, how to manage them.
Okay, thank you. Maybe short question. The last question I had is about chapter 8, so also a different one. It was about a prediction score you used. We heard comments about prediction scores and whether you should use them or not. It's about predicting patients with late ventricular arrhythmias who have an LVAD. You say standard ICD implantation is not recommended due to infection of the device, complications with the device. But how should we then use this VT score, prediction score. Because if you only implant in high risk or very high risk, there's still 45% in your cohort that wouldn't get an ICD. And what do you do with them? ILR and home monitoring and call them when they have a VT? I don't know.
I think we come again on the subject of scores and daily life in the hospital. I think we have the advantage of LVAD patients that we have time, that most of them, some of them remain asymptomatic. So to sum up, I think we can be a little restrictive when we give ICDs to LVAD patients, because even if they come with VT, they survive the VT, and we can do it on a secondary indication pattern.
Thank you.
Angeliki Darma, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
I will stand next to you. And I will make happy photos.
Angeliki Darma, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Vernooy is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Angeliki Darma, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary and the other members of the committee, and affixed with the official seal of the Maastricht University.
It's very nice.
Nikos. Stand here.
Yes, I was asked by Kevin to give the laudation, which I'm very happy to do so. So, dear Angeliki, I will pronounce it correctly because we are both Greek, and Angeliki is not the correct spelling of the first name, so dear Angeliki, congratulations. And I would like to say a few words because it's a huge achievement, what you have done so far, not only the diploma but all the other stuff. And we first met in 2015 when I came to Leipzig. So, and when I began my work there, you were not there in the first days, and I was told, oh, there is a Greek colleague there, Angeliki. So a few days later, we first met. And I was already in the first days impressed by your calm way that you behaved in clinical practice. I would call it in a very, very positive way, the silent way, because we all know how it is in clinical practice in big departments, and we're talking about an extremely active department, and where you find all types of personality, people completely convinced of themselves, knowing the absolute truth. And I was really very surprised to find this very calm approach, but very reliable in clinical assessment, very reliable in executing, I would say, the clinical work in a way that was best for patient safety and patient interest. And I had the great opportunity to watch all the development, the persistence and the patience with which you joined the VT ablation group, and how you then developed to a really extremely experienced VT ablationist. And I must say, in the last years of working there, and I had a really responsible position there, and whenever the telephone rang and you thought, oh my goodness, what am I going to do with this patient now? And we are talking about the most complex patients that you can find in clinical electrophysiology with high risk, where every decision that you make is really associated with a significant risk. I was very happy always, and I never hide that, to be able to call you and to ask, to consult with Angeliki, what are we going to do now with this patient? And I think most of the decisions that we made were, at least as decisions, very the best possible ones. So I followed this clinical development, which was amazing. And I was very happy for you that you continue that on that amazing scale in your new position. In parallel to that, I also had the opportunity to look at all the scientific work, and which was driven by persistence, focusing on this really difficult subset of patients. You don't find that many usually. And it was a scientific work of really great stability, on stable quality, stable high quality. So congratulations for that again. And I would like to close with DASCAM. I think I looked it up, but I could not find the file because it was back then when we were both in Leipzig. I think that I was one of the people who provided a recommendation letter for the DASCAM. And I will make it a little personal now. When DASCAM started, I had the privilege to be in the board of IRA. We were together there. And Harry Kreins and the board presented, the president presented to the board the idea of this educational program. And I was a little bit, I thought it is a little bit strange as a construction, with the aim to build the leadership of tomorrow. And that was 2016, I think, the discussions back then, and now it's obviously tomorrow has arrived. And I think Angeliki is a fantastic example, because this is what the DASCAM program was about. And for me, you're a living proof that this program has really absolutely met its purpose. So I'm really happy to have been able to go with you as a bystander, of course, all your way, to watch all this fantastic development and to see where you are now, where you stand now. And this diploma, this is the Sherry, and it's a true diploma. So I mean, we are both Greek, you know what I'm meaning now. It's something that you frame, put on the wall, and the parents are completely happy and they say, yes, that's what we did it all for. So congratulations, Angeliki.
Thank you very, very much.
Dear Dr. Darma, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. I also like to congratulate your family, friends, colleagues who one way or the other have supported you during this trajectory. It's a pity they are not present here, but probably they watch online and have followed the procedure. I also like to congratulate the supervisor with this nice PhD thesis. I'd like to thank the members of the degree committee for the time they have invested in preparing for this ceremony and being here. I have to excuse Dr. Boukens because he had to leave, so he's no longer present here. I can tell you that the degree committee was very satisfied with the way you defended your thesis. I hope you feel the same. It was clear that you are really on top of the topic and that you're able to connect science with your extensive clinical experience. And also, don't shy away from saying when you are not sure about something or you don't know or need more information, which is, I think, very good. Yeah, hopefully you also will look back with satisfaction on this ceremony. It must be quite an experience in a strange environment, but I hope you enjoy it. And for now, you can forget everything, relax, and enjoy the rest of the day. And with this, I close this academic ceremony.
Thank you very much.